Hello and welcome to today's video. Today we will cover part 2 of aortic stenosis. Please like the video if it was useful and subscribe to the channel. Let's begin. Natural history. Death in patients with severe AS occurs most commonly in the 7th and 8th decades. The average time to death after the onset of various symptoms can be remembered with the mnemonic ASDC3322. The average times are: angina pectoris to death, 3 years; syncope, 3 years; dyspnea, 2 years; and congestive heart failure, 1.5 to 2 years. More than 80% of patients who died with AS symptoms had existed for less than 4 years. Sudden death, which presumably resulted from an arrhythmia, occurred in 10 to 20%. Most sudden deaths occurred in patients who had previously been symptomatic. Sudden death as the first manifestation of severe AS is very uncommon. Only approximately 1% per year in asymptomatic adult patients. Progression of AS. Calcific AS is a progressive disease, with an annual reduction in valve area averaging 0.1 centimeters square and annual increases in the peak jet velocity and mean valve gradient averaging 0.3 meter per second and 7 millimeters of mercury respectively. Treatment of aortic stenosis. Medical management. In patients with severe AS, that is valve area less than 1 centimeter square, strenuous physical activity and competitive sport should be avoided, even in the asymptomatic stage. Avoid dehydration and hypovolemia to protect against a significant reduction in cardiac output. Medications used for the treatment of hypertension and coronary artery disease should be given. Beta blockers and angiotensin-converting enzyme inhibitors are generally safe for asymptomatic patients with preserved LV systolic function. Please note that as a dictum, afterload-reducing agents like ACE inhibitors are avoided in stenotic valvular lesions and fixed cardiac output states. Nitroglycerin can be given for angina pectoris in patients with coronary artery disease. Degenerative calcific AS who receive statins exhibit slower progression of leaflet calcification and aortic valve area reduction than those who do not. Remember how AS pathophysiology is similar to atherosclerosis. However, randomized prospective studies with either high-dose atorvastatin or combination simvastatin with ezetimibe have failed to show a measurable effect on valve-related outcomes. Therefore, the use of statins should be driven by considerations regarding primary and secondary prevention of atherosclerotic cardiovascular disease events. ACE inhibitors have not been studied prospectively for AS-related outcomes. The need for endocarditis prophylaxis is restricted to AS patients with a prior history of endocarditis. Surgical treatment. Asymptomatic patients with calcific AS and severe obstruction should be followed carefully for the development of symptoms and by serial echocardiograms for evidence of deteriorating LV function. Operation is indicated in the following cases. Number 1, patients with severe AS who are symptomatic. Number 2, those who exhibit LV systolic dysfunction. Number 3, those with bicuspid aortic valve disease and a root aneurysm or dilated ascending aorta. Remember how bicuspid valve is associated with root dilatation?
Number 4. Operation for aneurysm disease is recommended at smaller aortic diameters for patients with a family history of an aortic rupture and for patients who exhibit rapid aneurysm growth defined as more than 0.5 cm per year. These patients are high risk and you need to be careful, so they are operated earlier. Number 5. Patients with asymptomatic moderate or severe AS who are referred for coronary artery bypass grafting surgery should also have AVR. This is killing 2 birds with 1 stone. What is the operative risk of surgical aortic valve replacement in patients with AS? It is 2%, provided that the patient does not have heart failure. Next, we will discuss some relative indications for aortic valve replacement. Relative indications for surgery are: Number 1. An abnormal response to treadmill exercise. Number 2. Rapid progression of AS, especially when urgent access to medical care might be compromised. Number 3. Very severe AS without symptoms. Number 4. Excessive LV hypertrophy in the absence of systemic hypertension. Exercise testing can be safely performed in asymptomatic patients and as many as 1/3 of whom will show signs of functional impairment. Operation should be carried out promptly after symptom onset. This has to be within 1 to 3 months. In patients with low flow, low gradients of ERAS with reduced LV ejection fraction, the perioperative mortality risk is high. The mortality rate can be 15 to 20%, and evidence of myocardial disease may persist even when the operation is technically successful. In this group, long-term postoperative survival correlates with preoperative LV function. There is usually little choice but to advise valve replacement, especially in patients in whom contractile reserve can be demonstrated by dobutamine stress echocardiography, which is defined by a more than 20% increase in stroke volume after dobutamine challenge. Patients in this high surgical risk group may benefit from transaortic valve replacement, but data from RCTs in this population are lacking. The treatment of patients with low flow, low gradients of ERAS with normal LVEF is also difficult. Outcomes appear to be better with surgery compared with conservative medical care for symptomatic patients with this type of paradoxical low-flow AS, but more research is needed to guide therapeutic decision-making. In patients in whom severe AS and coronary artery disease coexist, relief of the AS and revascularization may sometimes result in striking clinical and hemodynamic improvement. Age alone is not a contraindication to surgical aortic valve replacement for AS. The 10-year survival rate of older adult patients with AVR is approximately 60%. Bioprostheses are favored for patients with age more than 65 years. For younger patients, we prefer metal valve. 30% of bioprosthetic valves fail in 10 years, requiring replacement. 30% of metal valves develop hemorrhagic complications as a consequence of treatment with vitamin K antagonists. Homograft AVR is usually reserved for patients with aortic valve endocarditis. The Ross procedure involves replacement of the diseased aortic valve with the autologous pulmonic valve and implantation of a homograft in the native pulmonic position. Its use has declined considerably in the United States because of the technical complexity of the procedure and the incidence of late postoperative aortic root dilation and autograft failure with AR. There is also a low incidence of pulmonary homograft stenosis. Percutaneous aortic balloon valvuloplasty, PABV. This procedure is preferable to operation in many children and young adults with congenital non-calcific AS, not commonly used as definitive therapy in adults with severe calcific AS because of a very high restenosis rate of 80% within 1 year and the risk of procedural complications. But sometimes it is used as a bridge to operation in patients with severe LV dysfunction and shock who are too ill to tolerate surgery. It is performed routinely as part of the TAVR procedure. Transcatheter aortic valve replacement. TAVR for treatment of AS has been performed with increasing frequency in prohibitive, high, and intermediate surgical risk adult patients worldwide using one of two available systems, a balloon expandable valve and a self-expanding valve, both of which incorporate a pericardial prosthesis. TAVR is most frequently performed via the transfemoral route, although trans-LV apical, subclavian, carotid, and ascending aortic routes have been used. Aortic balloon valvuloplasty under rapid RV pacing is performed as a first step to create an orifice of sufficient size for the prosthesis. Procedural success rates exceed 90%. Among elderly patients with severe AS who are considered inoperable, that is, prohibitive surgical risk, 1 and 2 year survival rates are significantly higher with TAVR compared with medical therapy, including percutaneous aortic balloon valvuloplasty. 1 and 2 year survival rates are essentially equal for high surgical risk patients treated with TAVR or surgical replacement. The 2-year rate of death or disabling stroke is lower in intermediate surgical risk patients who undergo transfemoral TAVR compared with surgical replacement. TAVR is associated with an early hazard for stroke and a higher incidence of post-procedural paravalvular AR, a risk factor for mortality over the next 2 years. The rate of post-procedural heart block requiring permanent pacemaker is significantly more common after TAVR. It is around 10%. Valve performance characteristics are excellent over 5 years. Longer-term durability assessment is ongoing, but results at 5 years are acceptable. An exciting innovation is valve-in-valve TAVR, where TAVR valve is inserted within an old valve. That's all for today's lecture. Thank you for your patient listening and have a good day.